Okay.
All right. Hi, everyone. Rachel, thank you for the introduction and the invitation to present again today with Project Echo. Um, I am going to kind of hop right in. I don't have any conflicts to declare. Some learning objectives today is to describe prenatal cell-free DNA screening, talk a little about considerations when selecting a test and the technology, identify some of the helpful language that you as providers can use in disclosing results, and then recognizing some limitations of the technology. So, a little overview. We know that about 3% of babies are born with congenital anomalies. The vast majority of those are due to multifactorial, teratogenic, or unknown etiology. Of the genetic causes for birth defects, up to 10% are due to single gene disorders, and then another 15% are due to chromosome abnormalities, which is what we'll be focusing on today. Chromosomes 21, 13, 18 are the chromosomes of interest that have been explored and interrogated using various screening methods, some of which you're familiar with historically, such as the first trimester screen, sequential screen, quad screen, etc. These common trisomies are the ones that are most likely to be viable and continue in a pregnancy, whereas other chromosome abnormalities are often lost early. The sex chromosomes have not historically been analyzed through traditional screening methods until the development of cell-free DNA technology. A little bit of the history. In 1997, Lowe discovered the presence of cell-free fetal DNA circulating in the maternal plasma. And then in 2008, they were able to successfully analyze that DNA for the detection of extra chromosome 21 material, which was a high risk detection for trisomy 21. Subsequent studies then established that that cell-free fetal DNA that was being analyzed was actually of placental origin, specifically trophoblastic cells circulating in mom's blood. This testing became available to us in the US in 2011, and since then, the cost of this testing has significantly decreased. We now are seeing insurance covering this testing, and there's also financial assistance available through the many labs that offer this type of testing. So overall, prenatal cell-free DNA screening, which I'll also just mentioned, historically, people called this NIPT or NIPS, non-invasive prenatal screening or non-invasive prenatal testing. It has been the recommendation from the American College of Medical Genetics and Genomics that we utilize the name of the technology rather than NIPT or NIPS. So for the purpose of the talk, I will be talking about prenatal cell-free DNA. So this is the most sensitive and specific screening test that we have for common aneuploidies. It has the lowest false positive rate, certainly in comparison to some of those more historical maternal serum screens like the first trimester and the quad screen. It is the only screening test that can screen for fetal sex aneuploidies. It does have an early gestational age as early as 9 weeks to allow for patient decision making. And then it is just a screening test. So this is not a diagnostic test. As such, many of our society guidelines do recommend that this screening be made available and offered to all women in pregnancy, regardless of their risk. And that is endorsed by the American College of Obstetrics and Gynecology, the International Society for Prenatal Diagnosis, and the American College of Medical Genomics and Genetics. One thing I'll also mention is that you will note if you're involved with any of this testing or if you offer any of this to your patients, there are offerings for microdeletion syndromes. Various laboratories have these available. Currently, the guidelines do not recommend using this technology for deletion screening, as the sensitivity, specificity, and positive predictive value are really difficult to estimate. If you have a patient who's motivated to understand all possible information about their pregnancy, chromosomal microarray should be made available and performed on a prenatal diagnosis sample if the patient is motivated to do so. So I will not go into great detail in this slide, but I just wanted to highlight that there are essentially two types of cell-free DNA technology. The first is the counting method, which was the very first one to be established back in 2011. And then the second is a SNP-based methodology, and SNP stands for single nucleotide polymorphisms. You can think of these as the subtle variances between humans. So the first method, which is depicted here in this picture, is essentially showing how you get cell-free DNA that's already in small fragments from the maternal bloodstream. And you basically build a library and you map the various regions of those chromosomes to the chromosomes that they are originating from. They are tagged, and these tags are then counted to establish the proportion of information for the chromosome numbers present. Um, the SNP-based technology is a little bit different because it's not counting all of that cell-free DNA that's present. It's actually differentiating between maternal and fetal genotypes. So because of the differences in the SNPs across the baby and across the mother, it allows for additional screening. So we can detect triploidy, which is when a fetus has an entire extra set of chromosomes. We can also detect zygosity of a twin pregnancy. So what all of the technologies are based upon and dependent on are fetal fraction. And you can think about fetal fraction as the total amount of cell-free DNA that's in maternal circulation. And so in that cell-free DNA, there are two types. You've got the cell-free DNA coming from the pregnancy, and then you also have the cell-free DNA coming from the mother. The DNA from the pregnancy is largely from the placental trophoblast. So it is not directly coming from the fetus, but from the trophoblastic cells of the placenta. And then the maternal cell-free DNA is coming from adipocytes and white blood cells. And so in order to calculate the fetal fraction, which has to meet a certain threshold for the analysis of cell-free DNA screening to even occur, you have to come up with the amount of that fetal or placental portion over the total portion of both fetal and maternal together. We know that this fetal fraction ranges from 10 to 15% between 10 and 20 weeks. That is average. We know that it is lower at an earlier gestation and that it does increase by about 0.1% weekly from 13 to 20 weeks. It then ramps up significantly in the mid to late second trimester. The minimum threshold for adequate performance of a cell-free DNA test is that the fetal fraction is between 2 and 4%. So for any fetal fraction that is less than that, analysis does not occur. And many of you are probably familiar with some of those results that come back saying low fetal fraction. And again, no analysis has happened. They have stopped there and issued the report to say there's just not enough of that cell-free fetal DNA in circulation to be able to run the technology. So this is just a little schematic that I think represents what I'm discussing. I share this with my patients as well, but it's just showing that the DNA is essentially coming from the placenta, not from the baby. I make sure to highlight that for my patients so they understand this to be a screening. This is not diagnostic. And then it also shows that you are getting some of that maternal DNA as well. So we have many factors that affect the level of fetal fraction. The two most common are gestational age and then maternal BMI. Studies have shown that obese patients have increased apoptosis or cell death in their adipose cells, which then results in elevated levels of maternal cell-free DNA. So if you think about if you have more maternal cell-free DNA, because of the fraction of the placental DNA, you often will get lower cell-free fetal DNA fraction because of the dilution within that maternal bloodstream. So we know that there is a inverse relationship between maternal BMI and fetal fraction. Similarly, as I mentioned, with the gestational age, we have a direct relationship there. The further along a pregnancy, the higher a fetal fraction should be. Okay, a few other factors we think about affecting fetal fraction is placental size. Some studies have found an association between low fetal fraction and placental dysfunction that may present itself as preeclampsia or fetal growth restriction. There are maternal factors playing a role. Women with hemoglobinopathies, which could include sickle cell disease, beta thalassemia, hemoglobin C disease, that they too have this increased maternal cell necrosis or cell death, again, diluting that fetal cell-free DNA. We know women who with active autoimmune disease may also have lower fetal fraction, and then women who are on anticoagulation therapy, so women on Lovenox during pregnancy, also have lower fetal fraction. Aneuploidy is another cause for low fetal fraction. We know that in babies affected with trisomies 13, 18, or triploidy, that size of those placentas tend to also be smaller, therefore a lower cell turnover from that placental trophoblast, therefore lower fetal fraction. And then lastly, multiple gestations. We know that the low fetal fractions are generally higher in twins. That does vary by chorionicity, as well as the platform that's being used. Oops, excuse me. Jumping ahead a bit. All right. So with all of that being said, what does that mean? How do we think about cell-free DNA testing for our patient population? So some considerations we should be thinking about is the mother's history. So what is her BMI? Is she taking any medication such as Lovenox, or does she have any medical conditions? Does she have sickle cell disease? Does she have active autoimmune disease? All of which should be considerations when performing cell-free DNA. Also, pregnancy history. If there are twin pregnancies, that might change what platform you decide to use. And then also, if a mom has recurrent first trimester loss, it may be that she shouldn't be offered cell-free DNA screening, but maybe she needs a workup done for a potential chromosome rearrangement herself, in which case a diagnostic test is going to suit her better. Family history can play a role. If you have a prior affected child, that can also inform maybe a better, more comprehensive diagnostic test rather than cell-free DNA screening. If you have a consanguineous couple, that can also affect cell-free DNA, especially the ones using the SNP-based technology, because the fetal and the maternal genotypes are so closely related due to this consanguineous relationship that the lab has a hard time distinguishing and providing accurate results. Also, something to consider is if you've done carrier screening on your patients and the patient and her partner are both carriers for the same recessive condition, prenatal diagnosis should be considered, and in which case cell-free DNA screening could probably be tabled, since you can then do a karyotype or a microarray directly on an amniotic fluid or a chorionic villi sampling. Insurance plays a role, certainly, not as much now as it used to. And then lastly, the collection of the DNA itself matters. So we know that if the maternal sample is collected using a butterfly needle, that needle has a higher gauge and tends to shred the DNA. So those patients will also come back with a lower fetal fraction. So I encourage everyone to share with their phlebotomy team to make sure they are not using butterfly needles in collection of DNA. All right, so when we are prepping our patients for this type of test, I like to tell them that we have a possibility of 3 results. We can get a low risk, a high risk, or an uninformative. That uninformative includes the possibility of a low fetal fraction or an atypical finding, which I'll talk about in a second. I highlight that this is not diagnostic or comprehensive. It's just looking at 5 of our 23 chromosomes, that it does allow for fetal sex prediction based on the presence or absence of the Y chromosome. And if we were to get a positive screening result, we recommend to have a diagnostic follow-up. And sometimes this screening test can be informative of a maternal chromosome abnormality, in which case it's necessary to do some chromosome testing on the mother. Post-test counseling, I make sure to include that this is a limited scope of screening. Again, only 5 chromosomes. I talk about that this low-risk result has greatly reduced the risk for one of these common aneuploidies. I make sure that the patient knows they should have an MS-AFP only after 15 weeks, not a quad screen, just pulling out that AFP by itself, because NIPS does not screen for neural tube defects. And then that the interpretation of this low-risk result or high-risk result should always be in the context of the clinical findings. So if you have ultrasound findings, family history, et cetera. This is not something I necessarily disclose to my patients unless it's necessary, but in the back of my mind, I'm always thinking when I have a high-risk result that this result is not always going to be representative of the fetus, but it could represent chromosomal changes from the mother, from the placenta, or from a vanished twin, or in some cases, it could represent fetal mosaicism in which the baby has 2 distinct cell lines. So just some patient-friendly language I'll share here with you if you're talking with patients about these types of screening results. I like to say for low-risk results that they have greatly reduced the chances, but have not eliminated them. The screening test evaluated for 5 chromosomes. If you want information on the other 18, prenatal diagnosis remains an option. I often get the follow-up question, so this means everything's okay with the baby. And my response to that is this is certainly very reassuring in regards to the conditions that we looked for. And I remind the patients that you're going to be having an anatomy scan around 20 weeks. If there's anything of concern, additional testing by prenatal diagnosis remains an available option to you. For those high-risk results, I talk about them showing an increased risk for whatever aneuploidy it is. I remind them it is not diagnostic. I do share the positive predictive value. This is a figure or statistic that is required to be reported on the lab, and that is providing the percentage that the positive result from the test is truly reflective of the baby. And I have a slide on that next. I talk about, the only way that we can be sure, the only way we can clarify this result is really to do something diagnostic, whether it's prenatal or postnatal. And I review those options with the patient. And then generally, we would expect next steps to include a maternal fetal medicine referral for a possible targeted ultrasound and genetic counseling to review those positive results. Positive predictive value, again, is a requirement by the ACMG to be included on all of these test reports. It is calculated based on the maternal age of the patient, along with the sensitivity specificity of that particular screen. And then it uses the incidence of the aneuploidy or trisomy in the population. So here you can see if we have a high-risk result for trisomy 21 at 16 weeks of pregnancy, that positive predictive value varies greatly in a 23-year-old, which is about 50%, to a 43-year-old, which is about 97%. And of course, that makes sense to us as with advancing maternal age, we know that there is an increased risk for chromosome abnormalities. But that is the positive predictive value can be a helpful tool in your counseling for that 23-year-old, that 50-50 chance versus that 43-year-old, you're nearing a more of a true positive result. So the uninformative result, there are essentially 2 types of uninformative results. The first one, which is that low fetal fraction we talked about. If your patient has a high BMI, a redraw is likely appropriate. I would not redraw it within a week. I would give it probably 3 weeks to allow that fetal fraction to increase a bit in the maternal bloodstream before doing a redraw. But in circumstances where, let's say you've tried two cell-free DNA screens, both of which have failed, it's probably the time to consider something diagnostic, or at least a conversation from genetics or MFM. If you have an atypical finding, these are different. Atypical findings are suggesting that there is a chromosome abnormality, but it's just outside that traditional scope of looking for those common trisomies. It may also suggest that there is a maternal chromosome abnormality. I like to encourage, my fellow genetic counselors. I tell my students this, that if you get information on a report that's confusing, they have genetic counselors at the lab that can actually look at the raw data in the background to provide some insight on that result. I will say the labs have gotten increasingly better at writing out exactly what they suspect the origin of that screening result to be. And also, if they are predicting it to be mosaic, or if they are predicting it to involve more than one chromosome, they are being much more transparent about that. And many times the reports do offer that level of detail. But when in doubt, just know they have a team of people there to help. And then, of course, if you get that atypical finding, do not redraw that. That is something where it needs to be worked up from a diagnostic standpoint. Okay, so if ultrasound findings corroborate a cell-free DNA screening result, do we still need diagnostic testing? So in other words, if you've got an AV canal defect on an anatomy scan and a high-risk trisomy 21 result on cell-free DNA, do we still need to be talking about amniocentesis or postnatal chromosome analysis? And the answer is yes, for a couple of reasons. The most important reason being you need to confirm the nature of that extra chromosome 21. There are 3 different types of Down syndrome. The most common is what we know of as trisomy 21, and that, of course, is sporadic. It is not inherited, but there can be rearrangements that are being carried by either parent that increases their risk in each pregnancy for a child with Down syndrome. And so it's important by doing a diagnostic test, whether that's during or after the pregnancy, to confirm that diagnosis as, is this an extra 21, or is this an unbalanced translocation that was inherited from a parent? Mosaicism can also be detected using diagnostic testing. Mosaicism can sometimes help with our, determining maybe that prognosis might not be as significant if it was a full-blown trisomy. That does get a little tricky, but sometimes having a mosaic result is helpful in explaining why we might not be seeing that level of birth defects or structural differences on an ultrasound. I already mentioned allowing for estimation of recurrence risk in a subsequent pregnancy. And then, of course, informing family history and other first-degree relatives of a potential recurrence risk. Okay, so my references. I now have some case presentations to go over.
So, Jessica, how are you? I was sending you a chat. So what we do, we're going to pause right now. So you can go ahead. I'm going to stop recording 1 second.